Welcome back to The Deep Dive, the show where we sift through the most complex topics to bring you the essential knowledge, giving you a real shortcut to being truly well-informed. Today, we're plunging into a field that is as challenging as it is critical: vascular trauma. Imagine injuries where every single second counts, where a mere delay in recognizing the problem or, a misstep in how it's handled can literally mean the difference between saving a limb or losing it, or even life and death. Despite incredible leaps forward in trauma systems, the risks here are still immense, and errors, maybe surprisingly, remain alarmingly common. Our journey today is founded on a comprehensive textbook chapter on vascular trauma from SABISTON's Textbook of Surgery. It's a foundational text that dives deep into everything from the insidious ways these injuries happen to the cutting-edge surgical techniques used to fix them, and crucially, the vital considerations for training the next generation of surgeons. Our mission is to cut through all that complexity, to extract the most important insights about vascular injury, how we diagnose it, and the rapidly evolving landscape of its treatment. By the end of this deep dive, you'll walk away not just informed, but with, I think, a genuine appreciation for the high stakes and remarkable advancements in this field.
And this really isn't just for medical professionals. This topic is universally relevant. Vascular trauma affects people from all walks of life, often completely unexpectedly, whether it's from blunt forces like a devastating car accident or penetrating injuries like, say, a gunshot wound. What we'll explore today: the formidable challenges surgeons face, the lightning-fast diagnostic pathways they navigate, the philosophical debates over different treatment approaches, and the ongoing, compelling push for better training and readiness. It's all about appreciating the incredible advancements that save lives and limbs every single day. It's about understanding the relentless dedication required to transform what can be, frankly, an error-prone process into what a timely diagnosis and safe, effective treatment. So get ready for some truly surprising facts, I think, nuanced insights, and a clear understanding of what makes these injuries so uniquely challenging. The nature of vascular trauma, mechanisms and pathophysiology.
Okay, let's unpack this. We're talking about blood vessels, our body's vital pipelines. So how do these critical injuries even happen, and what exactly goes wrong in the body when a blood vessel is traumatized? It's not just a simple cut, right? There's a whole cascade of events that can unfold, dictated by the type of force involved.
Exactly. Vascular injury can arise from two primary mechanisms: blunt trauma or penetrating trauma. And each creates a very distinct pattern of damage, with different implications for how the body responds and, crucially, how surgeons approach the repair. Understanding this difference is really foundational to managing these injuries effectively. Let's start with penetrating injuries, which are often what people first think of when they hear trauma. These, like those from a knife or a bullet, tend to be more discrete and produce a focused, localized injury along their track. Think of a knife wound; it creates a fairly clear-cut path of damage. Gunshot wounds, however, are far more variable, and their devastation depends entirely on the characteristics of both the weapon and the projectile itself.
So it's not like all bullets are created equal in terms of the damage they cause. That seems obvious, but maybe not the specifics.
Far from it. If we're talking about low-velocity projectiles, typically from a handgun, these travel at speeds less than about 2,500 feet per second. They tend to create more focal injuries with relatively little cavitation. Cavitation is the temporary cavity formed as the bullet passes through tissue. It's like a rapidly expanding and contracting bubble. With low velocity, that bubble is relatively small. But here's where it gets truly destructive: high velocity weapons, like military rifles, which propel bullets exceeding 2,500 feet per second. That's where the true devastation occurs, because the amount of kinetic energy transferred is just immense. Remember, energy equals mass times velocity squared, so even a small increase in speed has a disproportionately massive impact on the amount of damage. A high-velocity bullet creates a temporary cavity by violently expanding and contracting the tissue around its course. This cavity can reach a size up to 30 times the projectile's diameter, perpendicular to its track.
30 times? Wow, that's hard to even picture. It's devastating. Imagine that. The surrounding tissue is violently torn and stretched, often leading to catastrophic, widespread damage far beyond the bullet's direct path. And if that bullet strikes bone, well, then you get dangerous secondary projectiles, bone fragments, that inflict even more adjacent tissue damage. Essentially, shrapnel created from the patient's own body.
So it's not just the bullet itself, but the immense energy it imparts and these secondary projectiles that cause so much destruction. That's a critical distinction, and it really changes the surgical challenge, I imagine. What about shotgun wounds? They seem like a different beast altogether. Shotgun wounds are definitely a unique category. Their injury patterns are highly variable, determined by how close the victim is to the gunpowder load, and the size of the shot pellets. For very close-range shots, let's say within about 6 feet, the injuries are devastating and often lethal, almost resembling a single massive projectile impact. Intermediate-range injuries, maybe between 6 and 18 feet, are typically severe, with a wider pellet spread causing significant tissue damage. Beyond 18 feet, at long range, the pellets disperse widely, and the injuries might actually be surprisingly mild, sometimes only superficial. So proximity is absolutely everything with shotguns. Now, on the other side of the spectrum, we have blunt trauma. This type of injury is far more diffuse. What I mean by that is it produces damage not only to the vascular structures, but often to the surrounding bone, muscle, and nerves all at the same time. A significant concern with blunt injuries is that they can disrupt smaller collateral vessels, the body's natural sort of bypass routes, that would normally help supply blood flow if the main vessel is blocked. This disruption can actually worsen ischemia or tissue oxygen deprivation, because those backup routes are now compromised too. Classic examples the source gives include a supracondylar humerus fracture in the elbow, which carries a known risk of brachial artery injury or a knee dislocation. Knee dislocations put the popliteal artery, the main artery behind the knee, at significant risk due to stretching and tearing forces. Even severe crush injuries, sometimes without an obvious fracture, can result in serious vascular damage.
Okay, so we've seen how the body gets injured from the outside. But what happens inside the vessel once it's traumatized? What's the pathophysiology, the internal processes that unfold?
Well, the primary immediate consequence, and often the most life-threatening, is hemorrhage or bleeding. This occurs when all 3 layers of the vessel wall, the innermost intima, the muscular media, and the outermost adventitia, are disrupted or lacerated. If that bleeding is contained locally by surrounding tissue, it forms a hematoma, which is essentially a bruise that may or may not be pulsatile depending on the pressure. But if it's uncontrolled, it can lead to exsanguination, rapid, life-ending blood loss.
Now, here's where it gets really interesting and a bit counterintuitive based on the reading. You mentioned that sometimes a completely severed vessel might start bleeding, while a partially cut one bleeds profusely. Can you explain that paradox? It feels like a key insight into how the body reacts.
Absolutely. It's a fascinating, almost paradoxical effect of transection, and it's a vital takeaway from this deep dive. When an extremity vessel is completely severed, the muscular middle layer of the vessel wall, the media, often retracts and constricts due to spasm. The surrounding adventitia, the outermost layer, is also highly thrombogenic, meaning it actively promotes clot formation. Together, these actions can actually lead to the cessation of hemorrhage as the vessel effectively seals itself off. It's quite remarkable. However, a partially transected artery or vein cannot retract or thrombose effectively because the tear prevents the edges from coming together properly to seal. This often leads to much more extensive and persistent hemorrhage, which can be, devastating. This counterintuitive difference significantly impacts the surgeon's initial assessment and strategy. Beyond hemorrhage, another common pathophysiological response is arterial thrombosis. If the innermost layer of the vessel, the intima, is damaged, it exposes the underlying media, which is highly reactive. This exposure triggers local thrombus or clot formation. This clot can then propagate or grow, either completely including the lumen of the vessel or breaking off and traveling distally as an embolus, blocking blood flow further down the line. We also see situations where the injured intima can actually prolapse or sort of flip inwards into the lumen, partially or completely obstructing flow. And of course, external compression of the vessel from surrounding bone trauma or even just significant swelling can interrupt blood flow and produce thrombosis as well.
So it's not just the direct injury, but how the vessel reacts to it internally and what's happening around it that can compound the problem. What about spasm, that temporary constriction you mentioned?
Right. Spasm occurs when external trauma, like stretching or a significant bruise, stimulates the release of chemical mediators from damaged tissues, such as hemoglobin released from red blood cells. These mediators cause the vascular smooth muscle in the vessel wall to constrict, sometimes dramatically, significantly reducing the vessel's diameter and thereby critically reducing blood flow. This can starve downstream tissues of oxygen, even without a complete blockage. Now, what's particularly fascinating and a truly critical insight is how some of these injuries can be hidden, presenting themselves much later, like a ticking time bomb within the body. These are called subacute, chronic, or occult injuries, meaning they're not immediately obvious. The 2 most common are arteriovenous fistulas and pseudoaneurysms. An arteriovenous fistula, or AV fistula, typically occurs after a penetrating trauma injures both an artery and an adjacent vein. High-pressure arterial blood then follows the path of least resistance directly into the lower pressure vein, completely bypassing the essential capillary bed where oxygen exchange happens. This creates local signs like tenderness and swelling, but also regional ischemia, or lack of blood flow, to the tissues because of something called a steal phenomenon, where blood is basically diverted away from where it needs to go. In large fistulas, it can even lead to more systemic issues, like congestive heart failure, over time as the heart works harder to compensate.
And a pseudoaneurysm, you mentioned that's like a false sac of blood, not a true weakening of the whole vessel wall.
Exactly. A pseudoaneurysm is a result of a puncture or laceration of an artery that bleeds into and is then contained by the surrounding tissue, forming a false sac of blood. Unlike a true aneurysm, which involves all layers of the vessel wall bulging out, a pseudoaneurysm is contained only by the surrounding connective tissue. These can enlarge over time, causing local compressive symptoms on nerves or other structures. They can erode adjacent bone or, rarely, become a source of distal emboli, sending clots downstream. They can initially be clinically occult, meaning basically undetectable without specific imaging, but become symptomatic over time. This truly highlights the insidious and sometimes delayed nature of some of these vascular injuries.
From how these injuries originate and evolve, often in such hidden ways, let's now explore how skilled medical teams actually identify them. This often involves, I imagine, a mix of astute observation and some pretty high-tech diagnostics. 2, recognizing the injury, clinical presentation and diagnosis. So the body can react in so many ways to vascular trauma, from profound hemorrhagic shock, that's severe, life-threatening blood loss, to something as subtle as an asymptomatic bruit, which is what? A whooshing sound from turbulent blood flow that you can hear with a stethoscope. How do clinicians even begin to spot these critical injuries amidst other severe trauma, especially when a patient might have multiple life-threatening issues all happening at once? It seems like an incredibly complex puzzle.
It truly is a broad spectrum, and it demands an incredibly high index of suspicion from the entire trauma team. The first overarching rule, as outlined by Advanced Trauma Life Support, or ATLS principles, is that any patient presenting in hemorrhagic shock must be assumed to have a major vascular injury until definitively proven otherwise. That's the starting point. The location of the injury also heavily influences the potential for life-threatening blood loss, and this guides the initial approach. For example, in the head and neck, significant internal hemorrhage is typically limited by the relatively small, tightly organized tissue planes there. So usually it's external bleeding that leads to shock. However, in the chest, each side, or hemothorax, can easily accommodate lethal amounts of blood from injuries to the heart, lungs, or the great vessels, the large arteries and veins like the aorta and vena cava. Similarly, abdominal and pelvic vascular injuries can result in truly lethal hemorrhage, particularly from the aorta and the iliac arteries in the pelvis, which are major blood pipelines. For extremities, like the arms and legs, much like the head and neck, hemorrhagic shock usually only occurs if there's significant external blood loss. But, and this is crucial, you have to be wary of what might seem like a trivial neck or extremity laceration. It might have initially communicated with a major vessel, caused significant blood loss before arrival, and then clotted off. So the patient arrives in shock, but the obvious source isn't bleeding anymore.
So a seemingly minor wound could be a red herring, masking a major life-threatening injury that might have temporarily stopped bleeding. That really underscores the need for thoroughness and thinking about what happened before the hospital.
Exactly. That's why it's so important to get that pre-hospital information from emergency responders about the amount of blood estimated at the scene, and to thoroughly examine the patient for all wounds, not just the obvious ones. A relatively small number of vascular injuries also manifest in a delayed fashion. These can include thrombosis of a previously partially disrupted vessel that was initially still open, distal emboli clots breaking off and traveling downstream from an intimal tear, or the expansion or even rupture of an initially small pseudoaneurysm. So local signs like a growing hematoma, diminished or absent pulses, and patterns of associated injuries like fractures or nerve damage are key clues, even hours or days later. Because of this broad spectrum, the guiding principle is really to assume vascular injury is present until proven otherwise in all patients with hemorrhagic shock and all patients with significant extremity fractures or dislocations near major vessels.
This raises an important question. With such varied presentations, from the subtle to the catastrophic, what's the most effective, organized approach to rapid and accurate diagnosis, especially when every second counts in a busy trauma bay?
The physical examination is always the first and most critical line of defense, so to speak. Clinicians begin with a primary survey, following those ATLS principles. ATLS, again, stands for Advanced Trauma Life Support. and it's a standardized, systematic approach designed to rapidly assess and manage trauma patients in that initial critical period. Its core steps involve assessing the airway, ensuring adequate breathing and oxygenation ventilation, controlling circulation including hemorrhage, assessing disability or neurologic status, and exposure, meaningfully undressing the patient to find all injuries. Intravenous access is established immediately to begin resuscitation. Once the patient is stabilized enough after the primary survey, a secondary survey is performed. This includes a thorough history, if possible, and a careful head-to-toe physical examination. Key elements of this exam involve meticulously inspecting all injured sites and wounds, performing a complete sensory and motor assessment of the affected areas, especially the limbs, and meticulously checking pulses in each extremity comparing side to side is critical. It's also vital to note the presence of a hematoma, an audible bruit, that whooshing sound we mentioned, or a palpable thrill, which is a vibrating sensation you can feel over a vessel, often associated with an AV fistula. If distal pulses are diminished or absent, a continuous wave Doppler device, a handheld ultrasound, is used to compare ankle or wrist systolic blood pressure with the uninjured side. A significant difference, usually more than 10 millimeters of mercury, can indicate a vascular injury needing further investigation. Now, for classification and guiding immediate action, clinicians rely on distinguishing between hard versus soft findings of vascular injury. This is a really crucial distinction laid out in the guidelines. Hard findings indicate an immediate need for intervention, meaning the patient often goes straight to the operating room, sometimes bypassing extensive imaging. These include pulsatile bleeding, that's active, spurting blood synchronized with the heartbeat, an expanding hematoma, a bruise that's clearly and rapidly growing, a palpable thrill or audible bruit over a vessel, and clear evidence of extremity ischemia, which means the limb is acutely starved of blood flow. This ischemia is often remembered by the 6 Ps: pallor, paleness, paresthesia, numbness or tingling, paralysis, weakness or inability to move, pain, often out of proportion, pulselessness, and poikilothermia, which simply means the limb feels cold compared to the other side. Any patient with one or more of these hard findings needs immediate surgical evaluation, period.
Okay, so if you see any of those hard signs, it's basically straight to surgery, often without delay for extensive imaging unless it's instantly available. What about the soft findings then? What do those tell the team?
Soft findings indicate that while a vascular injury is definitely possible, maybe even likely, further imaging and evaluation are needed before deciding on surgery. The patient isn't necessarily crashing right that second from that specific potential injury. These include things like a history of moderate hemorrhage at the scene that's now stopped, the presence of a nearby fracture, dislocation, or penetrating wound in the path of the major vessel, a diminished but still palpable pulse compared to the other side, a peripheral nerve deficit close to a major vessel, or wounds near major vessels in patients who are in unexplained hemorrhagic shock. These patients aren't rushed directly to the OR based on these signs alone, but they absolutely need a rapid and thorough diagnostic workup, usually with imaging, to confirm or definitively rule out a significant vascular injury. This brings us neatly to imaging. While traditional catheter arteriography, where a catheter is threaded into the artery and contrast dye is injected, remains both sensitive and specific for diagnosing extremity vascular injuries, it does cause delays. It requires transporting the patient to a specialized angiography suite, mobilizing a team. It takes time. This is where computed tomography angiography, or CT angiography, has truly changed the game in recent years, especially with the latest generation multi-detector scanners. It's widely available in most trauma centers, it's highly accurate, and most importantly, as the source material puts it, it obviates the delay caused by mobilizing the angiography suite, meaning it gets rid of that time-consuming step. While it still requires intravenous contrast dye, it's less invasive, generally less costly, and significantly less time-consuming than conventional arteriography. In fact, a recent excellent review cited in the text conclusively established its superiority for diagnosing vascular injuries due to its speed, accuracy, and widespread availability.
So CT angiography is faster, less invasive, widely available. It seems like the clear front runner for diagnosis in most cases now. But you mentioned orchestration of imaging earlier. What does that mean in this high-pressure trauma environment? Is it just about picking the right test?
It's more than just picking one test. It means strategically combining different imaging modalities and sometimes interventional capabilities to meet the patient's specific needs in a timely and effective manner. For example, for severely injured patients who are too unstable to even go to the CT scanner and must go directly to the operating room for other life-threatening injuries, like a ruptured spleen, we can use an intraoperative arteriogram. This means that right there in the operating room, the surgical team can inject contrast directly into the artery proximal to the suspected injury and take an X-ray or use fluoroscopy, which is like live X-ray video, to quickly visualize the vessels. This way, we don't delay life-saving surgery for formal imaging outside the OR, but we still get crucial information about the vascular status. Now, while operative exploration, surgically opening the area to directly look at the vessel, is always an option if doubt remains after imaging or other tests, routine operative exploration for just soft signs in stable patients actually has a surprisingly high incidence of morbidity, between 5% and 30% according to the text, and often a low diagnostic yield. In other words, you operate and find nothing wrong with the vessel quite often. So these stable patients with only soft signs are, as the source states, generally better served with formal vascular imaging first. Lastly, duplex color flow imaging, which is ultrasound that shows blood flow, while very useful for other vascular conditions, is not typically used for the acute assessment of vascular trauma. Wounds, swelling, air trapped in the tissues, dressings. They all interfere with getting a clear picture. Its role is primarily in follow-up, for instance, assessing how well a bypass graft is working months later, detecting any narrowing or stenosis in a repaired vessel, or for ongoing surveillance of those minimal injuries we talked about earlier that are being managed non-operatively.
Okay, so a very multifaceted approach, starting with that crucial hands-on exam, then moving to targeted, usually rapid imaging like CTA, and reserving exploration for specific circumstances. With a clear diagnosis in hand, the next critical step is management. Let's delve into the different approaches, which sometimes, maybe surprisingly, don't involve immediate surgery at all. 3. Management approaches, a balancing act between techniques. Okay, here's where it gets really interesting for me because you think vascular injury, you think surgery, right? But not every vascular injury needs immediate surgical intervention. With the widespread use of CT angiography, clinicians are now detecting a lot of what are termed clinically insignificant lesions. What are these minimal injuries exactly, and how do we safely manage them without a trip to the OR?
That's absolutely right, and it represents a significant shift in refinement in vascular trauma management over the years. These minimal vascular injuries are often asymptomatic, meaning the patient has no symptoms related to them, and they typically don't progress to cause severe problems down the road. They include things like minor intimal irregularity, which is just slight damage to the innermost lining of a vessel, or small non-occlusive intimal flaps. These are little tears in the inner lining that flap in the bloodstream but don't actually block flow significantly. These flaps are actually the most common type of clinically insignificant injury found. They have a low likelihood. The text says less than 10% are progressing later to cause a complete blockage or send clots downstream. And if they do progress, it usually happens very early on, within the first day or two. Focal spasm, a temporary constriction of the vessel, is another minimal injury that should resolve quickly on its own. If it doesn't resolve promptly, that suggests a more serious underlying injury that needs addressing. Now, small pseudoaneurysms, those false aneurysms we discussed, are a bit different. While they can start small and be asymptomatic, they are considered more likely to progress or cause problems later, like rupture or embolization. So, they require active observation, usually with serial duplex color flow imaging, to make sure they're stable and resolving. And arteriovenous fistulas, as we discussed earlier, always enlarge over time due to the pressure difference, and should generally be promptly repaired, even if small initially. The good news is, there is now extensive evidence supporting non-operative therapy for many of these truly asymptomatic minimal lesions, like small intimal flaps or irregularities. The crucial caveat here, this is really important, is that successful non-operative therapy requires continuous surveillance. Usually this involves serial duplex ultrasound exams over days, weeks, and sometimes months to watch closely for any signs of progression, new blockage, or hemorrhage. If any of those occur, then operative therapy becomes necessary.
Okay, so non-operative management is a real option for carefully selected injuries, but it absolutely comes with that strict surveillance requirement. You can't just find it and forget it. Now let's talk about the other side of the coin. Endovascular management. This is the cutting edge, right? The less invasive approach using wires and catheters from inside the vessel that's getting so much attention across all of surgery. How does it apply here?
Yes, if we connect this to the bigger picture, endovascular techniques are undeniably transforming many areas of vascular surgery. They offer less invasive options that are increasingly common and often very effective, especially for stable, large vessel injuries, and in anatomic areas that are traditionally difficult to expose surgically for direct open repair, like deep in the chest, the pelvis, or the base of the skull. However, and this is a critical point, from the source material. It's crucial to understand that despite these remarkable advances, endovascular repair has not yet supplanted open surgery for the majority of peripheral vascular injuries, meaning those in the arms and legs.
That's a really important distinction. So, the success we see in elective cases like fixing aneurysms or blocked arteries in older patients using less invasive techniques doesn't necessarily directly translate one-to-one to the trauma setting, especially in younger patients with healthy vessels that are suddenly torn. And you mentioned earlier it's actually impacting surgeons' skill sets. How so?
Precisely. There's a strong tendency, maybe an understandable one, to generalize from our now extensive elective experience treating elderly patients with often calcified atherosclerotic arterial disease, where endovascular techniques are frequently the first choice, to managing acute vascular injuries in younger trauma patients whose vessel walls are often quite different. But the evidence to fully support this preference for peripheral arterial injuries and trauma is still developing, and frankly, as the source points out, there have been problems. This leads us directly to a significant concern raised in the text. The striking decrease in open vascular surgical experience among surgeons trained more recently, say, in the 21st century. This creates a real documented lack of comfort and competence in performing traditional open vascular repairs. It underscores the need for a balanced approach, using each technique, open and endovascular, where it best applies based on the injury, the patient, the available resources, and supported by clinical evidence to achieve the best possible outcomes. It's not about one being universally better. This challenge is also related to the infrastructure needed. This is where hybrid operating rooms come into play. Dedicated hybrid operating rooms are these incredibly high-technology suites equipped with both advanced fixed imaging capabilities, like a built-in angiography C-arm, and all the features of a traditional operating room. They're ideal for complex elective endovascular cases and can be used for trauma, but they require a major commitment of resources and specialized personnel. Not all trauma centers have them, or perhaps more importantly, can staff them 24/7 for emergency, often middle of the night, vascular trauma cases.
All right, so dedicated hybrid rooms are fantastic tools, but might not be universally available or practical for every emergency vascular trauma case. What's the more common or practical solution for most trauma centers then?
A more practical and increasingly common solution for many trauma centers are what the text calls hybrid operating rooms of opportunity. These are essentially created by bringing high-resolution digital subtraction C-arm fluoroscopy equipment, that's a high-quality mobile X-ray machine, along with mobile cabinets stocked with catheters, wires, balloons, and stent grafts, and on-call technical staff like radiology techs, into a standard operating room. You need to adapt a regular or R table to be fluoroscopy compatible, often using an orthopedic fracture table. But this setup allows management of unstable trauma patients needing both open and potential endovascular maneuvers right there, essentially replicating the functionality of a dedicated hybrid room. Many trauma centers already use this mobile capacity for some elective procedures, and the text emphasizes it's essential that all trauma centers develop this capability for their trauma patients facing acute vascular injuries. Now, let's look at some specific endovascular applications in trauma, because it really varies by location. For torsovascular injuries, these techniques offer a variety of crucial hemorrhage control options. For bleeding from solid organs like the liver, spleen, and kidneys, intra-arterial catheter directed embolization, where tiny coils or particles are deployed through a catheter to block the bleeding vessel, is often a mainstay. Less common but promising is intra-arterial balloon occlusion for proximal control, inserting a balloon into a major feeding artery upstream and inflating it to temporarily stop blood flow to allow for repair or other interventions. And retrograde endovascular balloon occlusion of the aorta, or REBOA, is increasingly used for exsanguinating abdominal or pelvic hemorrhage. REBOA involves placing a balloon catheter, usually via the femoral artery in the groin, up into the aorta and inflating it, either in the chest, zone 1, for abdominal bleeding, or lower down, zone 3, for pelvic bleeding, to temporarily stop massive hemorrhage below that point, buying precious time. These techniques, when performed by trained teams with the right equipment, can be quick, accurate, and life-saving. The text stresses that trauma surgeons need to adopt this technology through specific training or by ensuring specialists capable of performing these procedures are readily available on their call panels. Early use of catheter-directed embolization for pelvic fracture hemorrhage, for instance, is often very effective and considered superior to traditional open packing in many stable patients. Now, for intrathoracic grade vessels, particularly in blunt thoracic aortic injury, BTI, which, as we said, often occurs in high-speed car crashes or falls from height, endovascular stent graft placement has really become the procedure of choice in most major centers. Newer generation stent graft devices offer better proximal fixation and sealing, preventing some of the early catastrophic failures seen with older devices. If you compare endovascular techniques, often called TVAR for thoracic endovascular aortic repair, to traditional open repair for BTAI, the data, including large multi-center trials cited in the text, show significantly lower risks for major complications like spinal cord ischemia, leading to paraplegia, and stroke, less overall physiological impact on the patient, reduced blood loss, shorter operative times, and crucially, a lower risk of paraplegia.
Those are really impressive advantages, especially considering how devastating BTAI can be. But you mentioned caveats before, especially for these often younger trauma patients. Is there a catch here too?
There is a crucial caveat, yes. Patients who undergo endovascular repair, TVAR, for BTAI, require lifelong CT imaging surveillance. This is because there's still limited long-term data on how these grafts perform over decades in younger patients. There's a possibility of delayed endoleak, which is a persistent leak of blood into the aneurysm sac around the graft, and potential loss of device fixation or migration, as the aorta naturally enlarges and changes shape over a patient's lifetime. So while TVAR is often the most effective approach for surgically inaccessible injuries, or in patients deemed too high risk for open surgery, especially when stable, these techniques should ideally only be used in centers with an active elective endovascular practice and specific experience in treating trauma patients. The long-term implications and the need for lifelong follow-up are really important considerations. For cerebrovascular injuries in the head and neck, endovascular techniques offer distinct advantages where direct operative control is extremely difficult or dangerous, such as deep hemorrhage right at the base of the skull. Catheter-directed placement of detachable coils, balloons, or hemostatic agents delivered through a microcatheter can be genuinely life-saving to stop bleeding in these inaccessible areas. The role of placing stents in acutely injured carotid or vertebral arteries in trauma is still being defined and requires significant expertise and careful patient selection. If that high-level expertise isn't immediately available at the receiving hospital, prompt patient transfer to a specialized neurointerventional center should be strongly considered. Now, moving to the extremities, arms and legs, the use of stent grafts is becoming more common, but it's really important to echo the source material here. Long-term results have not yet been documented, and caution should still be used. While covered stents might be a good option to treat difficult-to-access proximal subclavian or iliac arterial injuries near the shoulder or hip, in stable patients with contained hemorrhage, for areas distal to these, like the brachial artery in the arm or the femoral and popliteal arteries in the leg, autologous vein interposition grafts using a patient's own vein, usually the saphenous vein from the leg, remain the gold standard with excellent documented long-term patency rates.
So again, despite the allure of a less invasive endovascular fix, especially in the arms and legs, the traditional open approach using the patient's own vein often remains superior for durability. That's a critical nuance that seems counterintuitive to the general trend towards endovascular everywhere else.
Precisely. And the text points out a concerning trend driven by that loss of open vascular surgery experience we discussed. Some surgeons may resort to endovascular repair in the extremities because they lack comfort or recent practice with the open techniques. This trend is described as particularly dangerous in the popliteal artery, end quote, behind the knee. There's a documented high risk of stent or endograft thrombosis clotting off in this location, often leading to severe limb-threatening ischemia. The text warns that early patency, meaning the graft is open initially, can unfortunately be followed by delayed thrombosis at an extremely high rate in the popliteal position. Open repair using a suitable saphenous vein interposition graft is still considered the best and most durable approach for most popliteal artery injuries requiring repair. Catheter-directed therapies like embolization are often effective for controlling hemorrhage from large branch vessels in the extremities, but endoliminal treatment, stents or grafts, is used sparingly for pseudoaneurysms of extremity arteries. Small ones often resolve on their own with observation, and large ones are usually best treated with open techniques due to the risks of thrombosis or distal embolization with endovascular intervention. This naturally leads to the question, who should perform these complex endovascular repairs in the trauma setting? The text gives a good answer. The most qualified person in the appropriate patient in the appropriate place at the appropriate time. Endovascular surgery is an operative procedure. It should be performed by readily available trained clinicians who are knowledgeable not just about the technical aspects of catheters and wires, but also about the underlying disease processes and the specific challenges of trauma. This often includes interventional radiologists, appropriately catheter-trained vascular surgeons, and increasingly trauma surgeons themselves who are gaining these essential skills, often through surgical critical care fellowships that now integrate endovascular training. Regardless of the specialty, it absolutely requires a committed, dedicated, collaborative, and well-trained team, including nurses and techs, ready to organize complex equipment with very brief notice, often, as the text says, in the middle of the night, because trauma certainly doesn't keep business hours.
Right. So, despite all these incredible high-tech advancements and the definite role for less invasive techniques in specific situations, it sounds like open surgery is still the enduring foundation, the bedrock, especially for many peripheral injuries, and certainly when endovascular options fail or aren't appropriate. How do we ensure excellence and readiness here in what often feels like the ultimate high-stakes surgical scenario?
It truly remains the foundation for many, many injuries, and ensuring readiness is paramount. Operative procedures for vascular injuries must be limited to surgeons who are capable, experienced, and qualified. Interestingly, the text makes a point that board certification in vascular surgery isn't necessarily enough on its own to qualify a surgeon for these complex trauma cases, nor does a lack of specific vascular board certification necessarily disqualify someone. Many surgeons who perform elective vascular surgery may lack sufficient recent trauma experience. Conversely, many dedicated trauma surgeons are highly skilled in vascular techniques simply due to their focused interest and extensive hands-on experience managing these injuries frequently. A telling multi-center review mentioned in the text, looking at nearly 700 major extremity vascular injuries, found that board-certified general surgeons and board-certified vascular surgeons had nearly identically high limb salvage rates. This really emphasizes that the surgeon's skill level and relevant experience are paramount, independent of their specific board preparation pathway. The bottom line is every designated trauma center needs a readily available call panel of surgeons who possess the full spectrum of vascular trauma repair skills, both open and potentially endovascular, 24 hours a day, 7 days a week. Successful operative management requires a very systematic approach with careful preparation. This begins immediately upon the patient's arrival with ensuring airway control, securing adequate intravenous access, often large bore IVs, and having blood products immediately available. A crucial point here, highlighted in the text, is controlled resuscitation, sometimes called permissive hypotension. Unless the patient is profoundly hypotensive, blood product administration shouldn't begin aggressively before hemorrhage control is achieved or imminent in the OR. The goal is to provide just enough volume resuscitation, typically using balanced components like O-negative packed red blood cells and fresh frozen plasma in a ratio to support transport to the operating room for definitive hemorrhage control without delay.
Infusing too much volume too early, which might raise the blood pressure significantly above, say, 90-100 millimeter Hg systolic before the bleeding is stopped surgically, can actually increase bleeding by dislodging early clots and worsen outcomes, especially if it delays getting the patient to the OR for that definitive repair. Broad-spectrum preoperative antibiotics are given, especially for penetrating wounds, along with tetanus toxoid if indicated. For an isolated extremity injury without significant ongoing hemorrhage or other major injuries, a bolus of 5,000 units of heparin, a blood thinner, can be given intravenously just before vessel clamping to help prevent clotting in the stagnant blood distal to the injury. However, systemic heparinization should generally be avoided in patients with associated torso, head, or multiple extremity injuries due to the significant risk of increasing internal bleeding elsewhere in the body.
And there's a critical, often missed step in this preparation phase, isn't there? Something mentioned in the source that could lead to serious medico-legal consequences if overlooked.
Yes, a very, very important point, and the text calls it the most commonly omitted step in preparation. That is failing to adequately document the preoperative extremity neurologic status. Why is this so critical? Because a new neurologic deficit like new numbness, tingling, weakness, or paralysis appearing after a vascular repair is a major red flag. It potentially indicates ongoing ischemia to the nerves, possibly due to a problem with the repair or developing compartment syndrome, and it necessitates immediate investigation and possible reoperation. Without knowing the baseline neurologic function before the surgery, it's incredibly difficult, maybe impossible, to determine if a new deficit has actually occurred postoperatively versus being present from the initial trauma. So a thorough preoperative neurologic examination and careful, clear documentation are absolutely essential. They provide that vital reference point. The operative management of extremity vascular injuries also must be carefully coordinated with the patient's overall care plan. The decision between attempting a definitive, potentially time-consuming vascular repair versus employing rapid damage control measures needs to be made early. especially when an extremity vascular injury is associated with other major torso injuries or severe head injuries requiring simultaneous attention. This might involve having two surgical teams working simultaneously on different parts of the body. Early involvement of orthopedic and plastic surgery consultants is also vital for associated complex soft tissue and bone injuries. They can help with preoperative planning, perhaps discussing a staged approach, maybe damage control with shunt placement first, followed by orthopedic stabilization to fix fractures, which then removes the extreme urgency for immediate blood flow restoration. And they are crucial later for assisting with wound closure and potentially covering exposed grafts or fractures with muscle flaps.
Right. So when a patient is truly in extremis, that critical, unstable state where they might be bleeding to death, hypothermic and coagulopathic, you can't always do the perfect time-consuming repair immediately. This is where damage control surgery comes in, correct? It's about stopping the bleeding, controlling contamination, and getting the patient stabilized first, even if it means a temporary fix for the vessel.
Exactly. Vascular damage control has gained wide acceptance as a key strategy in modern trauma surgery. The focus is on rapid control of life-threatening hemorrhage and any associated enteric wounds like bowel perforations that spill contaminants to allow the patient to be quickly transferred to the ICU for warming, resuscitation, and correction of coagulopathy, blood clotting problems, and acidosis. The choice between attempting a definitive, often complex and time-consuming vascular repair versus using temporary measures must be made early by the surgeon, especially when dealing with major associated torso injuries. The two mainstays of vascular damage control are ligation, simply tying off the vessel, and the placement of temporary intraluminal shunts. Ligation should generally be reserved for injuries to vessels that have adequate distal collateral blood flow, meaning other vessels can supply the area, and only in patients who are simply too unstable physiologically to tolerate more complex repair at that moment.
Examples given in the text where ligation might be considered in an unstable patient include the subclavian and innominate arteries in the chest neck region, the celiac artery supplying some upper abdominal organs, and the inferior mesenteric artery supplying the left colon. In the upper extremity, the proximal axillary artery or the distal radial or ulnar arteries might be ligated if there's clearly adequate collateral flow to the hand confirmed by exam or Doppler. In the groin, the profunda femoris artery, deep femoral, can sometimes be ligated if the main common and superficial femoral arteries are intact. In the lower leg, a single injured tibial artery or the peroneal artery can potentially be ligated if the other two main calf vessels are known to be patent and providing good flow. However, ligation of the superior mesenteric artery, SMA, which supplies a large portion of the small and large bowel, carries a very high risk of subsequent bowel necrosis, so damage control there is best accomplished with a shunt if repair isn't immediately possible.
And critically, ligation of the brachial artery in the arm, or the external iliac, superficial femoral, SFA, or popliteal arteries in the leg, carries a high likelihood of producing limb-threatening ischemia, and should be avoided if possible, according to the source. If repair isn't feasible immediately in these critical limb arteries, then an intraluminal shunt should be inserted instead of ligation.
Okay, so shunts are absolutely critical for damage control in those major limb arteries to preserve the limb while the patient stabilizes. What kind of shunts are we talking about? Are they specialized devices? How do they work?
A variety of commercially manufactured vascular shunts are available now, often made of silicone or similar materials, in various sizes. But in an emergency, even readily available sterile heel V tubing can be adapted and used effectively as a temporary shunt for both arteries and veins. Interestingly, the text notes that placing a venous shunt, instead of simply ligating a major injured vein, like the femoral or popliteal vein, may actually improve overall extremity perfusion and potentially lower the risk of developing compartment syndrome later. Shunt placement involves getting proximal and distal control of the injured vessel ends, clearing out any thrombus or clot, and instilling some regional heparinized saline solution into the vessels to help prevent new clots from forming around the shunt. The shunt must be placed so it lies in a relatively straight line, without kinking, and it needs to be long enough to be secured firmly, usually with vessel loops or ties around the outside of the vessel over the shunt. It's important to note that the ties used to secure shunts can cause some intimal damage to the vessel wall underneath. Therefore, those specific portions of the artery where the ties were placed must be carefully resected or trimmed back at the time of the definitive repair later on. The timing of that definitive repair is determined entirely by the patient's overall physiological condition. Hemorrhage must be controlled systemically, any coagulopathy and acidosis must be corrected, and the patient's body temperature must be normalized. Only when the patient is deemed stable enough can the more complex definitive vascular reconstruction take place. often 12-48 hours later. When it comes to the definitive choice of repair and the graft material used, vessel injuries that can't be repaired by simply mobilizing the ends slightly and stitching them directly together, called primary end-to-end anastomosis, will require an interposition graft to bridge the gap. The most desirable graft material, especially for smaller arteries in the extremities, is the autologous great saphenous vein, which is harvested, usually from an uninjured leg. This is widely considered the gold standard for repairing smaller vessels like the popliteal and tibial arteries. Why? Because it's elastic compliant, stretches similarly to an artery. It closely approximates the artery's diameter. It's not thrombogenic, less likely to clot, and it offers superior documented long-term patency compared to any prosthetic material in these locations. Other veins, like the cephalic vein from the arm or the lesser saphenous vein from the leg, can be used as second choices, but they often have limitations in terms of size or length. If a suitable saphenous vein isn't available, maybe it was previously harvested for heart surgery or it's injured or just too small, then a prosthetic conduit, such as polytetrafluoroethylene, PTFE, which is a type of synthetic polymer graft, may be needed. Early experiences using other synthetic grafts like Dacron in trauma settings were quite poor, with high complication rates including infection and thrombosis. However, more recent experience with modern PTFE grafts shows improved patency, reported as 70%, 90% short-term, and surprisingly rare infection, even when used in contaminated wounds, which is a major advantage.
PTFE grafts can provide early patency rates equivalent to vein for injuries in larger, more proximal arteries, like the brachial artery in the upper arm, or arteries proximal to the popliteal artery in the thigh, like the femoral artery. However, distal to these levels, specifically for the popliteal artery and the tibial vessels in the lower leg PTFE, is considered inferior to vein in terms of long-term patency. And critically, the text states that PTFE grafts less than 6 millimeters in diameter should generally not be used for arterial reconstruction, as their long-term success rate is quite poor. Regardless of the material used, vein or PTFE, all vascular repairs must be covered by healthy soft tissue to prevent desiccation, drying out, and subsequent disruption or infection. For extensive soft tissue loss around the injury site, early involvement of a plastic and reconstructive surgeon is essential. Local muscle flaps can sometimes be mobilized to cover the graft, or in cases of large contaminated wounds, early re-exploration and preparation for a free flap transferring healthy tissue with its own blood supply from another part of the body might be necessary.
Sometimes, extensive tissue loss even requires routing the graft through an extra anatomic course, meaning outside its normal pathway, just to get it under healthy tissue cover. Attention to ensuring adequate soft tissue coverage is also essential during damage control procedures to prevent shunt dislodgement or exposure. Intraoperative imaging and non-invasive evaluation are crucial tools for assessing the technical success of a vascular repair before closing the patient. While preoperative imaging isn't always possible or might be outdated by the time of surgery, post-repair assessment is key to detecting potential problems like residual thrombus, kinking of the graft, or other technical issues that could cause early failure. Intraoperative radiographic imaging, either single injection, one-shot radiography, or using fluoroscopy with contrast injection right there in the operating room, is considered the most accurate and useful method to detect these technical problems or identify any remaining clot in the runoff vessels downstream from the repair. The text notes that performing routine completion arteriography after major vascular repairs yields clinically important findings, meaning findings that change management in about 10% of patients. So it's definitely worthwhile. While intraoperative duplex scanning, ultrasound, and using a handheld continuous wave Doppler probe can also be helpful adjuncts, they require significant training and experience to interpret accurately in the operative setting. Simple ankle or wrist pressure measurements after repair can sometimes be misleading due to temporary vasospasm caused by the injury or surgery itself. Now, I want to emphasize a critical point that the source material highlights very strongly, because failure here can lead to devastating yet preventable consequences. Failure to perform an adequate fasciotomy after revascularization of an acutely ischemic limb is the most common cause of preventable limb loss. Let me repeat that. The most common cause of preventable limb loss. Calf compartment syndrome is the most frequent indication for fasciotomy, often resulting from prolonged ischemia, lack of blood flow before repair, or from a severe crutch injury mechanism. Forearm compartment syndromes are also common, and thigh compartment syndromes occur less frequently, but can happen. Essentially, any muscle group enclosed by tight fascia can develop compartment syndrome.
So it's not just about successfully restoring blood flow to the limb, but also ensuring the limb doesn't swell up so much afterwards that it essentially suffocates itself from the inside due to pressure buildup in those tight muscle compartments. How is compartment syndrome diagnosed then, especially since the classic sign everyone thinks of, losing a pulse, is actually a very late and a very bad sign?
Exactly. Compartment syndrome can manifest immediately after reperfusion or be delayed, sometimes developing 12 to 24 hours after blood flow is restored. If it's not promptly diagnosed and treated by surgically releasing the pressure, a fasciotomy, the risk of permanent muscle and nerve damage, leading to limb loss or severe functional disability, is extremely high. Initial clinical signs typically include escalating pain, often described as out of proportion to the visible injury, and loss of light touch sensation in the distribution of the nerves running through the affected compartment. You should strongly suspect it if a patient complains of increasing pain after injury or revascularization. Other signs include a visibly tense, swollen compartment that feels hard or woody when palpated, pain elicited by passively stretching the muscles within that compartment, and progressive loss of sensation or development of muscle weakness. Crucially, as you pointed out, the loss of arterial pulses is a late finding in compartment syndrome and indicates a very poor prognosis, often meaning irreversible muscle and nerve damage has already occurred. Neurologic signs can also be misleading, especially in the upper extremity, due to frequently associated direct nerve injuries from the initial trauma complicating the assessment. Therefore, early diagnosis often relies on directly measuring the pressure within the muscle compartments using a specialized needle and pressure monitor. Normal compartment pressure is typically 0.9 millimeters of mercury. While there's some debate on the exact threshold, the safest approach, recommended in the text, is to perform a fasciotomy, making long surgical incisions through the skin and the fascia overlying the affected compartments to release the pressure, whenever the measured compartment pressure exceeds about 25 to 30 millimeters of mercury, or if clinical suspicion is very high, even with slightly lower pressures. The role of immediate amputation in the initial management of complex extremity vascular injuries is actually very limited, according to the source. For patients presenting with truly devastating injuries involving extensive soft tissue loss, significant irreversible neurologic deficit, multiple complex bone fractures, and associated vascular injuries, a collaborative evaluation involving orthopedic surgeons, neurosurgeons if applicable, and plastic reconstructive surgery colleagues is key to determining if primary immediate amputation might be the best initial management strategy to save the patient's life or provide the best long-term functional outcome. Scoring systems designed to predict the likelihood of eventual amputation based on initial injury severity, like the Mangled Extremity Severity Score, MES-SS, have generally not proven consistently useful in clinical practice for making this difficult decision definitively upfront. Often the best approach, especially if the patient is physiologically stable enough, is to proceed with an initial intraoperative evaluation, thorough documentation including pictures, radiographs, and detailed consultation notes, temporary damage control measures like intravascular shunts to restore perfusion temporarily, and then plan for a second look surgery 24 to 48 hours later. This interval allows time for further resuscitation, clear assessment of tissue viability, communication with the patient and family about the prognosis and options, and ultimately a more planned, deliberate approach to either limb salvage or delayed amputation if salvage is deemed futile. Immediate amputation is generally reserved for situations where the patient has truly life-threatening torso injuries that demand all the physiological reserve, combined with an obviously non-viable, severely disrupted extremity. In these rare cases, extensive documentation, including photographs, is very helpful later for patient and family acceptance of the decision.
That makes sense, giving time for a clearer picture when possible. But this whole process seems fraught with potential challenges. Even with organized approaches, established protocols, and experienced teams, what are the most common and perhaps devastating errors in managing vascular trauma that surgeons must constantly work to avoid? What are the key pitfalls that can lead to those poor outcomes we want to prevent?
That's a critical question, and awareness of these common pitfalls is absolutely key to preventing them. The text highlights several recurring themes. One of the most common errors is simply a lack of recognition of a significant extremity vascular injury, particularly in a patient who presents with multiple distracting, life-threatening torso injuries. The team might be so focused, understandably, on the immediately life-threatening core injuries that a limb vascular injury gets missed or delayed in diagnosis. Another devastating and frequently cited error, as we just discussed at length, is the failure to recognize and adequately treat compartment syndrome in a timely manner, which can lead to irreversible neuromuscular damage and limb loss. In the context of major torso injuries involving the great vessels, like the aorta or vena cava, failure to adequately expose and gain proximal and distal control of the injured site before uncontrolled bleeding occurs can lead to rapid death from exsanguination right there on the operating table. And finally, Related to the damage control principles we covered, failure to recognize the need for damage control techniques, trying to do too much complex surgery on an unstable patient, and failure to rapidly complete the initial operation in a physiologically deteriorating patient can also be deadly. The text acknowledges that contributing factors like surgeon fatigue, distractions in a busy trauma center environment, and even sometimes overfamiliarity leading to complacency are inherent to the process of care at busy trauma centers. So, having a highly organized, systematic, team-based approach with clear protocols and frequent communication is crucial to mitigate these risks and intercept potential errors before they cause harm.
Okay, so we've covered the general principles, the diagnostic approaches, the management techniques, both endovascular and open, damage control, and the critical pitfalls that surgeons face. Now, maybe we can briefly touch on how these principles play out with specific types of vascular injuries in different parts of the body, as each anatomic area seems to present unique challenges and considerations based on the outline. We probably can't go into every single vessel, but maybe highlight the key takeaways for the major regions.
Absolutely, that's a good way to synthesize it. For head, neck, and thoracic outlet vascular injuries, management is often particularly challenging due to the density of vital structures. Major vessels, nerves, airway, esophagus, all clustered in these confined spaces. Penetrating trauma in the neck is often managed based on anatomical zones. Zone 1, low neck chest entry. Zone 2, mid neck. Zone 3, high neck base of skull. In stable patients with suspected injury in Zone 1 or 3, vascular imaging, usually CT angiography, is considered mandatory. Imaging is also generally recommended for stable Zone 2 injuries, although direct surgical exploration might be chosen for expanding hematomas or signs of airway compromise. Sometimes a Foley catheter with the balloon inflated in the wound track can provide temporary campanade pressure to control bleeding. Conventional angiography still has a role here for diagnosis and potential endoluminal management, like coiling bleeding branches or placing covered stents in selected cases. Blunt cerebrovascular injuries, BCVIs, which affect the carotid and vertebral arteries running through the neck, are often occult, meaning not immediately obvious, and can be initially asymptomatic.
Rapid diagnostic screening using specific criteria, often called the Denver criteria or expanded Memphis criteria, triggered by certain fracture patterns, like basilar skull fractures involving the carotid canal, complex facial fractures or cervical spine fractures, or neurologic signs, is essential because the incidence is now recognized to be much higher, 10-20 times, than initially thought. These injuries, caused by stretching, tearing, or direct blunt force, range in severity from minor luminal irregularity, grade 1, to complete transection with active bleeding, grade V. Treatment usually involves anticoagulation or antiplatelet agents like aspirin to prevent stroke, depending on the grade and presence of other injuries. The role of endovascular stents is still limited and evolving, but embolization or covered stents might be best for specific inaccessible injuries like those at the skull base or involving the vertebral artery within the bone. Thoracic outlet vascular injuries involve the large subclavian vessels passing between the clavicle and first rib. Exposure and control here are notoriously difficult, often requiring complex incisions like a supraclavicular approach combined with sternotomy or thoracotomy. There's a high risk of injury to nearby nerves like the vagus, phrenic, or recurrent laryngeal during clamp application. Sometimes resecting the clavicle is necessary for rapid hemorrhage control. Endovascular balloon occlusion can be an excellent adjunctive measure for proximal control here as well. Moving down into the chest, intrathoracic great vessel injuries involving the aorta, superior or inferior venae cavity, or the pulmonary arteries and veins often cause immediate death at the scene due to massive rapid hemorrhage. Survivors who reach the hospital are typically profoundly unstable and require emergent operative intervention, usually via a median sternotomy, splitting the breastbone, or an enterolateral thoracotomy, incision through the side of the chest. Blunt thoracic aortic injury, BTAI, is a prime example, often resulting from high-energy blunt trauma like those severe car accidents or falls from significant height. As mentioned, the vast majority, 85 to 90%, die at the scene.
For survivors, diagnosis is typically confirmed by high-resolution chest CT angiography. Initial management focuses on strict blood pressure and heart rate control, usually with a short-acting intravenous beta blocker like esmolol, aiming to keep the systolic BP below 110 mmHg and heart rate below 100 BPM to reduce stress on the injured aortic wall. Definitive repair, either endovascular or open, is often strategically delayed until other concomitant life-threatening injuries are dealt with, as attempting immediate complex aortic repair in a multiply injured patient was historically linked to increased mortality. As we discussed, endovascular repair, TVAR, is now the first choice at most centers due to documented lower morbidity and mortality compared to traditional open repair. But remember that crucial caveat about lifelong imaging surveillance being necessary, especially in younger patients, as a long-term durability is still being studied. Open repair still has a definite role, particularly in patients with anatomy unfavorable for endovascular grafts. Now, into the abdomen.
Abdominal vascular injuries most often result from penetrating trauma, gunshot stabbings, and are typically managed via a generous midline laparotomy incision from xiphoid to pubis. Often, initial control of major bleeding requires temporary clamping of the aorta high up near the diaphragm, supraceliac control. Abdominal aorta injuries themselves are best exposed to repaired using a technique called left medial visceral rotation, mobilizing the left-sided organs towards the midline. Simple stab wounds might be repaired primarily, while more destructive gunshot wounds often require patch repair or an interposition graft. Blunt aortic injuries without life-threatening hemorrhage are increasingly managed with endovascular stent grafts if anatomically suitable. The inferior vena cava, IVC, the body's largest vein, is usually exposed using right medial visceral rotation. Direct digital pressure can control bleeding initially, then vessel loops are used. Simple anterior or lateral injuries are often repaired primarily with sutures, ensuring the lumen isn't narrowed by more than 50%. Repairing posterior injuries is more complex, often requiring mobilizing the IVC.
Complex destructive injuries may require patch repair, grafting, shunting, or sometimes ligation, tying it off. Ligation is considered an option primarily for hemodynamically unstable patients, especially for injuries at or above the level of the renal veins, although ligating the right renal vein typically necessitates removing the right kidney. For iliac arteries and veins in the pelvis, exposure requires mobilizing the overlying colon, cecum on the right, sigmoid on the left. The ureters run nearby and must be carefully identified and protected. Common and external iliac arteries are critical for leg perfusion and should never be ligated electively. Repair is done primarily or using a synthetic interposition graft. PTFE is common here. If the patient is unstable, placing a temporary shunt for delayed repair is the damage control approach to save the limb. The internal iliac artery, hypogastric however, supplies pelvic structures with rich collaterals and can often be ligated safely if needed to control bleeding. Iliac veins are exposed similarly. Simple injuries are repaired primarily.
Complex or destructive venous injuries are often best managed by ligation rather than attempting a complex, time-consuming repair that's prone to thrombosis. Mesenteric vessel injuries, those supplying the intestines, are notoriously challenging. The celiac trunk supplying the stomach, spleen, and liver is often difficult to repair, and ligation is generally well tolerated due to extensive collateral circulation. The superior mesenteric artery, SMA, however, is critical, supplying most of the small bowel and right colon. The text emphasizes that SMA injuries, except very distal ones, should always be repaired if possible, using primary repair, end-to-end anastomosis, or ideally a reversed saphenous vein interposition graft. If the patient is in extremis, the SMA may be temporarily shunted for delayed repair, as ligation carries a very high risk of massive bowel necrosis. The superior mesenteric vein, SMV, is managed similarly. Repair or reconstruction when possible, shunting as damage control, or ligation only if the patient is truly unstable. The inferior mesenteric artery and vein, supplying the left colon, can usually be safely ligated due to collateral flow from the SMA via the marginal artery.
Portal vein injuries, collecting blood from the intestines to the liver, are also managed like SMV injuries. Repair construction is preferred, shunting is an option, and ligation is a last resort in extremis. Renal vascular injuries to the kidney's artery or vein are usually exposed after medial visceral rotation. Penetrating renal artery injuries are managed with repair, primary, patch, graft, or sometimes nephrectomy, kidney removal, after confirming the other kidney is normal and functioning. Renal vein injuries are managed by primary repair or ligation. Left renal vein ligation is usually safe due to collaterals, but right renal vein ligation typically requires nephrectomy. Combined artery and vein injuries often lead to nephrectomy, especially in unstable patients. Interestingly, blunt renal artery injuries, often occlusions from stretching, are rare, often managed non-operatively if stable or with nephrectomy. Successful salvage of kidney function with reconstruction after a complete blunt renal artery occlusion is unfortunately uncommon. Now for the upper extremity. Presentation here differs.
Penetrating injuries usually present with obvious arterial hemorrhage or ongoing bleeding, while blunt trauma often leads to thrombosis, acute arterial occlusion, and signs of ischemia, pain, pallor, pulselessness. There's a very high rate of associated neurologic injury, particularly to the median nerve, occurring in about 60% of patients with major vascular injuries here. Concomitant venous injury is also common. These injuries can be easily missed in patients with multiple other distracting injuries, and delay in diagnosis is a major factor in preventable limb loss or long-term disability. Diagnosis is often made by physical examination alone, especially for penetrating injuries with hard signs. Non-invasive evaluation often adds little in the acute setting. Patients with obvious lacerations or hard findings go directly to the OR. If pulses are absent with complex fractures or crush injuries, imaging, CT or conventional angiography, is needed if perfusion doesn't return quickly after resuscitation and pain control. Management. The text clearly states there is currently not a role for endovascular therapy in the brachial artery and forearm vessels.
Traditional open surgical exposure, catheter thrombectomy, clot removal, and repair remain the best approach. Damage control with arterial shunt placement is used for unstable patients. A multidisciplinary approach involving orthopedics, neurosurgery for nerve exploration repair, and plastic surgery is often essential. Venous injuries can usually be ligated unless there's extensive soft tissue injury or loss of major venous collaterals, in which case repair is preferred. Bleeding control during initial resuscitation is crucial. Tourniquets are life-saving. Wide surgical preparation of the entire limb is needed. Systemic heparinization is usually avoided if there are associated head injuries. Local or regional heparin infusion into the distal vessel might be used instead. Loop magnification and headlights are essential for visualizing and repairing smaller vessels accurately. Surgical exposure. The brachial artery is typically exposed via a longitudinal incision on the medial aspect of the upper arm. This can be extended across the antecubital fossa, elbow crease, for forearm vessel exposure. Proximal brachial control might require extending the incision up towards the axial and infraclavicular approach.
After exposure, thrombus is cleared and vessel ends are debrided, trimmed back to healthy tissue. Lacerated veins are usually ligated, but if repair is needed due to extensive injury, the vein is often repaired first to improve outflow. Primary arterial repair, end-to-end, is only done if it's completely tension-free. Otherwise, a reverse saphenous vein interposition graft is preferred. PTFE is considered a second choice for brachial forearm arteries if vein is unavailable. Fasciotomy. Forearm fasciotomy should always be strongly considered, especially after prolonged ischemia or significant swelling. Compartment pressure should be measured intraoperatively and monitored closely postoperatively. Amputation. Primary yearly amputation has a limited but important role for truly catastrophic injuries with extensive soft tissue loss, severe irreversible neurologic deficits, complex unstable fractures, and associated vascular injuries. An intraoperative multidisciplinary assessment, damage control, and a planned second-look surgery in 24-48 hours is often the preferred approach rather than immediate amputation. Distal injuries. For combined ulnar and radial artery injuries in the forearm, at least one vessel should be repaired. The ulnar artery is usually larger and a better target proximally. For isolated ulnar or radial artery injuries, ligation is only acceptable if there is absolute certainty of adequate collateral flow to the hand through the remaining vessel and the palmar arch, confirmed by inspecting the hand's perfusion, palpating pulses if possible, and using a Doppler. Finally, lower extremity vascular injuries. These are actually more common in military settings, reported 30-40% of vascular injuries, than civilian trauma, around 20%. But blunt vascular trauma remains a significant cause in civilian settings. Associated injuries. Fractures and dislocations in the thigh and leg are common companions. The popliteal artery, located right behind the knee joint, is at particularly high risk of injury after a knee dislocation due to the significant stretching and tearing forces involved. Presentation diagnosis. Presentation varies widely, from significant hemorrhage to occult arterial occlusion, presenting as an ischemic limb. A systematic approach with a thorough vascular examination, including ABI measurements, angle brachial index using Doppler, is essential to avoid diagnostic errors. Surgical exposure. Incisions are generally similar to those used for elective lower extremity bypass procedures. The common femoral artery in the groin is exposed via a longitudinal incision. Proximal control might require exposing the external iliac artery higher up through an oblique muscle-splitting abdominal incision. Superficial femoral artery, SFA injuries, are exposed via extensions of the longitudinal groin incision. Mid-SFA injuries might need an oblique incision over the sartorius muscle. Popliteal artery injuries require a generous medial incision, often needing division of the medial head of the gastrocnemius and the hamstring tendons, semimembranosus, tendinosus, for adequate exposure above and below the knee. Distal popliteal and proximal tibial vessels are exposed via an incision along the posterior aspect of the tibia. Repair. Repair below the inguinal ligament usually requires an interposition graft. Reverse saphenous vein harvested from the contralateral uninjured extremity is the first choice.
PTFE is considered an acceptable alternative for the common femoral artery if saphenous vein is insufficient or unavailable, but saphenous vein remains the best graft for the SFA, popliteal, and tibial vessels due to superior long-term patency in these locations. Tibial vessels. Below the popliteal artery, injuries to the three main calf vessels, anterior tibial, posterior tibial, peroneal, are often managed by ligation if at least two of the three vessels are patent and providing adequate collateral flow to the foot. If flow is compromised, for example both anterior and posterior tibial arteries are occluded, then the peroneal artery alone is usually insufficient, and repair of at least one injured tubular vessel is necessary. The choice of which vessel to repair depends on the extent of soft tissue injury and the quality of the distal vessel runoff observed on imaging or intraoperatively. Damage control. Techniques using temporary arterial and venous shunt placement are particularly important for managing lower extremity vascular injuries associated with major torso injuries and hemodynamic instability.
Achieving physiological stability rapidly allows for timely definitive repair, which is crucial to prevent shunt thrombosis and the detrimental effects of prolonged limb ischemia. Fasciotomy. As mentioned, fasciotomy is frequently required for calf compartment syndrome, but also potentially for thigh compartments. These require generous incisions through specific approaches, for example, four-compartment release for the calf, often via 2 incisions, to adequately decompress all involved muscle groups. Hand and foot compartment syndromes are less common, but also require specific fasciotomy techniques, usually managed by orthopedic or hand surgeons. 4. Postoperative care and long-term outcomes.
Okay, so the patient has made it through the initial trauma, the diagnosis, the complex surgery, whether open, endo, or damage control, followed by definitive repair. Once that acute repair is done and the immediate crisis seems managed, the journey isn't over, is it? What happens next, and what are the crucial steps in that postoperative phase to ensure long-term limb and life preservation after such a severe injury? It sounds like ongoing vigilance remains absolutely key.
You're absolutely right. The journey is definitely not over at the operating room door. The cornerstone of postoperative management, as the text puts it, is truly vigilant and close follow-up, specifically looking for any changes in the vascular examination findings of the injured extremity. This means frequent, meticulous assessment of the patient's vital signs, carefully checking the distal extremity pulse quality, monitoring the signal using a continuous wave Doppler device, assessing capillary refill time in the fingers or toes, and performing detailed neurologic examinations, checking sensation and motor function of the injured limb. These checks need to happen very regularly, especially in the first 24-48 hours. If there's any concern raised during these assessments, a weakening pulse, a change in Doppler signal, new numbness or weakness, an immediate return to the operating room may avert a potentially limb-threatening problem. The text notes that failure of a vascular repair due to thrombosis or clotting off can certainly occur, most commonly within the first 48 hours postoperatively, so that careful, frequent follow-up should continue for at least that long, if not longer depending on the situation.
Delayed complications are also a significant concern that requires vigilance. Reperfusion edema, which is swelling that naturally occurs after blood flow is restored to a limb that was ischemic, deprived of oxygen for a period, or even intracompartmental hemorrhage leading into the muscle compartments after repair, can lead to a delayed onset of compartment syndrome. This might not become apparent until 12 or even 24 hours after the initial reperfusion. Physical examination alone might not be sensitive enough to detect developing compartment syndrome, especially in patients who are unconscious, sedated, or otherwise uncooperative postoperatively. In these cases, frequent postoperative compartment pressure measurements are the only way to accurately assess the injured extremity, as the source emphasizes. And remember that point about neurologic checks. A new postoperative extremity neurologic deficit is considered an important indicator of ongoing ischemia, and should immediately prompt a thorough assessment of both the patency of the vascular repair and the pressures within the muscle compartments.
That risk of delayed compartment syndrome, even a day later, is a powerful reminder that vigilance can't stop just because the surgery seemed successful initially. What about the longer-term outcomes and the ongoing follow-up needed for these patients? What are the lasting effects they might face, and what do they need to look out for, maybe years down the line?
That's a great question. Looking at the long term, the text points out that the most common cause of amputation after vascular injury is actually the neurologic insult, resulting either from direct trauma to the major nerves during the initial injury or from prolonged ischemia, the lack of blood flow, damaging the nerves irreversibly. The ultimate functional outcome for a salvaged limb is therefore highly related to the severity of the associated injuries of muscle, bone, and nerve, perhaps even more so than the technical success of the vascular repair itself. A perfectly repaired artery supplying a limb with non-functional nerves and destroyed muscle won't result in a useful limb. Because of the potential for late complications, long-term surveillance is absolutely necessary for patients who have had significant vascular repairs. Ideally, they should be seen in follow-up, perhaps yearly or as indicated, to assess the ongoing patency of the repair and, importantly, to detect any late complications that might develop over time.
These late issues can include things like aneurysmal dilation, where a segment of a vein graft weakens and bulges out over years, or the development of segmental stenosis, which is narrowing within vein grafts. Patients might develop chronic venous insufficiency, swelling, skin changes, if a major vein was ligated. They could also experience thrombosis of a previously stable pseudoaneurysm, or even the late development of an arteriovenous fistula that wasn't apparent initially. Regular pulse examinations and sometimes non-invasive imaging, like duplex ultrasound scans, should be performed periodically as part of this long-term follow-up. If there's any clinical suspicion of a late complication based on symptoms or exam findings, then more advanced imaging like CT angiography or conventional catheter angiography might be needed to investigate further. For patients who had major torsovascular injuries repaired, there are relatively few common late complications once they've healed successfully.
Occurrence. Those with venous interposition grafts or repairs to the aorta and iliac arteries should be observed similarly for any signs of developing arterial occlusive disease later in life, such as claudication, pain with walking. And a very practical point, patients who receive synthetic interposition grafts like PTFE should be counseled on the need for antibiotic prophylaxis before undergoing subsequent dental work or other invasive procedures throughout their lives. This is because these artificial grafts are potentially susceptible to bacterial seeding and subsequent infection, even years later. They should also be made aware of the rare but real possibility of late infections specifically related to the prosthesis itself. V. The critical need for training and preparation in vascular trauma. Now, if we really connect all of this to the bigger picture, looking forward, a profound challenge is emerging in how surgeons are trained specifically in vascular trauma, and it directly impacts the ability of healthcare systems to consistently deliver effective, life-saving care for these critical injuries. Vascular surgery, perhaps more than many other surgical fields, inherently carries a high risk of technical surgical error. Getting it right requires precision, good judgment, and often significant experience. And the optimal treatment of vascular trauma remains challenging and is rapidly evolving, as we've discussed with the interplay of open and endovascular techniques. But here's a crucial insight from the text, and perhaps the most critical point for the future of trauma care readiness. There is a striking decline in open repair experience among recently trained surgeons. The widespread preference for endovascular techniques for elective vascular surgery, coupled with fewer and fewer open vascular surgery cases overall in training programs, has produced a documented shortage of surgeons who feel capable of and comfortable in performing open vascular repairs for vascular trauma. This steadily decreasing volume of open vascular procedures, encountered during both general surgery residencies and even specialized vascular surgery fellowships, has significantly eroded the skill level of both the frontline trauma surgeons and the supporting vascular surgeons they rely on for complex cases.
That's a truly sobering reality. It sounds like the very hands-on skills that have saved countless lives for decades through traditional open surgery are potentially diminishing in the upcoming generation of surgeons. What does this mean specifically for training programs? How bad is the decline?
It represents a fundamental shift, and the numbers cited are quite stark. For example, the text mentions that the average general surgery resident today manages less than one vascular trauma case during their entire residency. Many participate in 5 or fewer open aortic aneurysm repairs, which used to be a cornerstone of general surgery training. This is a dramatic difference from just 2 decades ago. Vascular fellowship training, the next level of specialization, is also heavily impacted. While fellows gain much more endovascular experience, there's an alarming decrease in open arterial procedures. The text cites up to a 65% decrease in open arterial reconstruction volume compared to previous eras. Many graduating vascular fellows today will simply not see 100 major open cases like aortic repairs in their first 10 to 15 years of practice. There's an old saying mentioned that it takes maybe 50 to 100 aortic repairs before a surgeon's initial fear of operating on the aorta transforms into profound respect and competence. Few training programs can provide that volume of open experience now. This creates a significant fear factor among newly trained surgeons when they're inevitably faced with major open vascular emergencies, like a ruptured aorta or a complex trauma case, where endovascular techniques might not be an option or might fail. The text concludes this section with a very strong statement. The paucity of capable vascular surgical emergency backup represents a threat to most of our trauma and emergency centers. This isn't just a theoretical problem, it's described as a looming crisis that directly impacts emergency readiness across the board, potentially affecting patient outcomes.
Wow, that's a truly concerning outlook. This decline in hands-on open surgical experience could leave a dangerous gap in our emergency care capabilities, especially for those situations where endovascular just isn't the answer or isn't available. So, what does this all mean for the future of trauma care? How are medical educators and institutions trying to find innovative solutions to address this critical skill gap, especially when those traditional hands-on opportunities are clearly shrinking?
It means we simply cannot expect current training program structures alone to mitigate this developing lack of competence without adding additional educational content, specifically focusing on these areas of limited experience, particularly complex open vascular exposures and repairs. While simulation technology is promising, the text notes it has yet to accomplish the vision that it can replace actual experience entirely, although it's becoming an increasingly important adjunct. Some alternative avenues for gaining relevant open experience are being explored, such as maximizing resident participation in the vascular dissection aspects of abdominal organ harvest procedures performed by transplantation teams, which provides valuable exposure to major vessel anatomy and handling. But the text highlights two particularly promising approaches that are being implemented more formally in residency and fellowship training to address this gap. One is to actively audit the case logs of general surgery residents and vascular fellowship trainees to specifically detect which trainees are falling behind on experience with major abdominal or thoracic vascular procedures. These complex open cases are now precious training opportunities and need to be shared equitably among trainees. Crucially, the text emphasizes the trainee must be taught by actually performing the procedure, not simply watching or retracting. This requires patience and forbearance from the attending surgeons to allow the trainee to work through the steps, even if it takes longer. This hands-on experience should be preceded by thoughtful didactic preparation, so the operative experience has maximum educational impact, and followed by rigorous post-procedure debriefings to discuss decision points, technical nuances, and troubleshooting. The second important opportunity is participation in specialized hands-on surgical skills courses. The American College of Surgeons sponsors courses like the Advanced Surgical Skills for Exposure and Trauma ASSET course, which focuses specifically on teaching the operative exposures needed for trauma, and the Advanced Trauma Operative Management ATOM course, which uses a live animal model for practicing operative procedures. These combine focused didactic material with cadaver or live animal dissection and have been highly successful in improving both the knowledge and skill set of participants. Similarly, international collaborations have developed courses like the Definitive Surgical Trauma Care (DSTC) course and the Definitive Surgical Trauma Skills (DSTS) course, which also provide excellent surgical training in trauma surgery decision-making, crucial vascular exposures, and fundamental vascular repairs using simulation models. Many centers are also now developing perfused cadaver labs for high-fidelity simulation training, which is particularly relevant to learning complex vascular exposures. In these labs, trainees can dissect along pressurized cadaver vessels that simulate bleeding, allowing them to learn exposure techniques and practice methods for gaining proximal and distal control in a realistic yet low-stakes environment. Their performance can be recorded, critiqued by experienced faculty, and then they can repeat the procedure to demonstrate improvement. This approach has shown demonstrable results in improving operative skills in the trauma centers where it has been effectively implemented.
That sounds like a really powerful way to help bridge that experience gap. It's obviously not the same as operating on a live patient in an emergency, but it gets trainees much closer to the reality of the operating room environment and the technical challenges involved.
Exactly. And it allows for focused practice and feedback in a way that's just not possible during a real trauma resuscitation. This all leads to a final critical point from the source material. This raises the question: if this trend of declining open surgical experience continues without effective mitigation strategies, what are the broader implications for public health and emergency readiness nationwide, and what urgent steps must be taken to prevent a genuine crisis? The text warns that the rapidly disappearing knowledge and experience base of major open vascular surgical technique truly threatens all trauma centers' ability to provide effective care for patients with major vascular injury and other vascular emergencies. It starkly states that not taking action assures a crisis in the near future that will result in poor outcomes. Therefore, new education strategies are called for. We need to combine getting the maximal education value out of a decreasing number of key open cases with requiring participation in appropriate courses that use cadaver and live animal operative experience to partially mitigate this looming deficit. Simulation technology must achieve its full promise to augment real operative experience and become an important, validated method for both acquiring and maintaining these critical skills throughout a surgeon's career. The text concludes by saying the over 100-year history of major advances in the management of vascular injuries, largely led by dedicated surgeons with a specific interest in trauma, absolutely needs to be sustained. Finding and implementing these innovative ways of training and preparation will be essential to ensure that the art and the science of the surgical management of these incredibly challenging injuries will endure for generations to come. Outro.
We've certainly covered an immense amount of ground today, diving deep into the immense complexity and the undeniably high stakes of vascular trauma. From really understanding the devastating mechanisms of injury, whether it's blunt force from a crash or penetrating trauma from a weapon, to appreciating the ingenuity of the diagnostic methods, ranging from that immediate hands-on physical exam to cutting-edge CT angiography, and exploring that evolving yet clearly delicate balance between traditional open surgery and the newer endovascular techniques. We've also highlighted the absolutely critical importance of adaptable and robust specialized training in what is clearly an ever-changing surgical landscape. It's truly eye-opening, I think, to understand the hard facts behind these often life-saving interventions and to appreciate the dedication of the surgeons and teams who continue to innovate and work tirelessly to uphold these critical surgical skills against significant headwinds.
And that leads us nicely to a final, maybe provocative thought for you, our listeners, to consider. Given the profound impact of these evolving surgical techniques in this shifting landscape of training, particularly the well-documented decline in open surgical experience, what implications does this have for equitable access to high-level vascular trauma care? Especially thinking about underserved or remote areas, where access to cutting-edge hybrid ORs and highly specialized experienced surgeons might be limited. What broader societal investments might be needed in training, in systems, and regionalization perhaps, to ensure that this vital expertise remains accessible for everyone who might face such a sudden, potentially life-altering injury, regardless of where they happen to live or when that injury occurs? It's a crucial question, I believe, for public health policy and medical education moving forward, ensuring that these truly life-saving skills are always within reach, no matter where or when trauma strikes.